next speaker is speaking from Calgary, which makes it 8 o'clock her time. And then she has to go to rounds, and she's also been dealing with that E. coli outbreak. So, addressing vaccine hesitancy in your everyday practice. Dr. Cora Constantinescu is a pediatrician, infectious disease physician, and clinical associate professor in Calgary, Alberta. From seeing vaccine hesitant patients in clinic to her academic pursuits in vaccine acceptance and surveillance, she has a strong passion for vaccine research and promotion. She holds a master's in medical education and specializes in development and study of education interventions rooted in behavioral change theory. She has applied these skills to vaccine education for healthcare workers and the public, and continues to be a vaccine advocate at the local and national levels. Welcome, Cora.
Thank you very much for having me. Hello, everybody. I hope you can see my slides. Is that, can I get a thumbs up or somebody virtually pat me on the shoulder if you cannot? So thank you
I
very
can
much.
see them.
Good. Thank you very much for having me. I just wanted to cover my disclosures. I do have, I've worked over the last few years a lot with a number of pharmaceutical companies, including having done talks that were sponsored by pharmaceutical companies. However, any of the money or including honoraria have either gone directly to my university, not to me, or I have declined them. The only honoraria I have accepted was from the Canadian Research Network. Okay, so we're going to talk for the next 20 minutes a bit about vaccine hesitancy, and what's really exciting is that I'm actually working with one of my fantastic colleague who's actually a respirologist in Calgary, and she has a huge interest in vaccine hesitancy in immunocompromised populations, specifically in lung transplant populations. So a lot of what I'm about to tell you is actually going to be applied. We're working on some exciting educational initiatives, including some virtual simulation games that we're going to apply in very much the population you're all looking after and serving. And so I think it's become so much more relevant over the last few years. We had always known about vaccine hesitancy before. We were dealing with it in pediatrics, but the pandemic has really brought this to a world scale and really catapulted this into the adult vaccine hesitancy, which had not been as well recognized as the pediatric vaccine hesitancy. So really, this is just one slide about what really is vaccine hesitancy. And I want you to keep in mind that it's an attitude or a sentiment. See how it gets at emotion here, like a sentiment and an attitude, whereas the actual vaccination is an action or behavior. So when we try to address vaccine hesitancy, you have to bridge this from sentiment to action. And we now know that simple, straight up, didactic education is not enough to make that, to bridge that gap. And when people make the vaccine decision, this action, timing is really important. That personal moment that they're in their lives, and then the historical moment. What else is going on in the world at the time when they have to discuss vaccination? And one of the best, probably one-liners about this is that really vaccine hesitancy has to do with distrustful complacency. So this interactive combination of low concern about the disease and the threat that it is to them, and low trust in the healthcare system and in the vaccine that's being offered. And that low concern and low trust is what we try to leverage when we use vaccine, when we do vaccine hesitancy initiatives. And we know that post-pandemic, there's been a significant drop in coverage. This is actually the largest sustained backslide in childhood immunizations in 30 years. And it's easy to say childhood because that's what we tend to measure, and that's most of the surveillance that we have. But you can imagine that the adult vaccines have also significantly dropped, of course, with the exception of COVID. But Canada early childhood vaccines dropped across board, and the biggest drop was in school-based delivery because of the school closures, and the biggest drop was in those kids who are equity seeking, because equity of vaccine access is the most easily done via school-based delivery. And when you don't have that, then all of a sudden you're struggling with access for for parents and the ones who are equity seeking are the ones that suffer the most in this. Now, some of this coverage has fluctuated, and some of this coverage has rebounded because of huge efforts on public health side to bring these numbers back up. But if you also look worldwide, we have 67 million million children who missed out on vaccinations in that 3-year period. And 48 million didn't receive a single routine vaccine. That's called the zero dose. So 48 million children across the world have now received a vaccine over that 3-year pandemic period. And then to explain some of that, we now also know there has been a post-pandemic drop in vaccine confidence, and that has declined by 8.2 percentage points in Canada. And I tell you, we were not at perfect, herd immunity or community protection levels to begin with. And we know that the younger people, those under 35, are most likely to report less confidence about vaccines. So, what builds this confidence and why has this dropped so much? A few theories out there. Um, the public question the importance of vaccination more than ever. And then in that, you have the political polarization, these libertarian views. And we've always had alternative health advocacy, but just think back on the pandemic and all the various alternative options that the people, would hang on to, hoping that they would cure COVID. And then you have that in a hyper connected digital landscape. So now people could self organize with shared beliefs across geographic regions. We knew from before that that having common ground with somebody on something non vaccine related would translate into vaccination behavior. So if you felt something in common with somebody, let's say something in common is a religious component or political views, then you were more likely to buy into their vaccine views as well. Well, now they could self organize across the entire globe with this hyper-connected digital ability. And we also had these healthcare providers, a lot of burnout, faced with a huge number of questions, trying to navigate all the information coming at us. And a lot of healthcare providers report they feeling hesitant themselves about accepting, but also about recommending vaccines. And I'll tell you a bit later why that's important. So it's no surprise that we're seeing a recurrence or resurgence of vaccine preventable diseases. We heard about measles, we heard about meningococcus. I'm sure you all remember the awful influenza season we had last year. And Alberta is still in the midst of a whooping cough outbreak. And now we know that there is a significant cost to this misinformation. So we've always known it in a clinical sense because we've seen people come in with these vaccine preventable diseases. But the cost of misinformation has now, by the Council of Canada, academies being put together as an actual cost of that. So we know that the spread has cost, that COVID-19 misinformation cost over 2,800 lives and $300 million in hospital expenses. And then this misinformation contributed to over 2 million Canadians refusing to get the COVID vaccine. And if they had been vaccinated, we would have had roughly 200,000 fewer COVID cases and 13,000 fewer hospitalizations. So it's nice to see that there is an actual cost attributed to this misinformation because we've always known that it was clinically seeing our patients in hospital. So what can we do to increase confidence and uptake? Well, here is my dream slide to you. And I say that because I could talk about this for hours, a variety of things we could do. But I'm just going to hit on 4 things that we can talk about. The first aspect of this is before you can reach herd immunity, you have to reach herd influence. We cannot aim for vaccine uptake if we haven't changed that sentiment, that attitude. We can't get to that behavior. So here are some things we can do on a one-on-one, but also at the public health level, messaging that we can address. Whenever we talk vaccine confidence messaging, and now we have data showing this, there are 2 important things about it. One, people see the vaccine as a way for personal protection. Now, there are some groups for whom collective responsibility matters, as in, I'm taking the vaccine to save others. but that is not the norm. So most of people will, especially adults, and even and a lot of pediatric decision making is around personal protection. So if they don't see the vaccine as beneficial to themselves personally, then they're not going to go ahead and have the vaccine. It's hard for us as healthcare providers to buy into that idea. We love talking about collective responsibility, but the reality is that is not how people make vaccination decisions. And then the other component that's really important is that it has to come from a trusted source. We'll talk a little bit about what that trusted source means. We know that if you had to talk about any, if you didn't know a lot about a vaccine, the top main content issues that come up are safety and side effects. That's at the top as a top concern. And what helps to bridge that gap to the vaccination behavior is complacency and altered risk calculation. And we saw that through COVID so much that it was all fine and dandy to want to have the vaccine, but nobody really did until the COVID cases were really increasing and they felt the personal threat of the disease. So that's what it comes to, that complacency. So as long, and even now, when you see about it, when the most common messaging you hear about influenza and COVID, vaccine for people who don't want to take it is that they have good immune systems, they're healthy, therefore they don't want to take it. So it's this complacency, this sense that, oh, well, it's not going to happen to me. Other people may be at risk, but not me. So how do we leverage some of this? It's this idea of acknowledging the disease as a vaccine preventable threat as healthcare workers. We need to do this more and more. Influenza is a vaccine preventable threat. COVID is a vaccine preventable threat in terms of severe infection, which is really what we care about to keep people out of hospital. So these are vaccine preventable diseases, and we need to address them as that. Peer pressure is really important. We've done work that showed that peer pressure is how people make decisions around vaccination. It's no surprise because that's how people make decisions about a lot of things. So here it helps to establish vaccination as the norm. And I say that respiratory virus is included. And in some ways, because influenza and RSV and COVID are these potentially these seasonal infections, they always seem to be somehow seen as less important than the routine vaccinations. So we need to establish them as the norm on the actual schedules. And here, what's really important is improved access, and I'll talk a little bit about that as well. And then what you can do in terms of one-on-one interaction is to build a positive interaction with each healthcare visit. We've done work on our vaccine hesitant cohort, and these are parents of children. So it might be different in adult populations, even though I doubt it. I think there's a lot of the same reasons at the bottom of, of decisions. But we learned that if parents had a positive interaction with a healthcare provider, they were more, even that had nothing to do with vaccines, they were more likely to go ahead and vaccinate. So it goes to show that you can still help the vaccination effort without even talking about vaccines. So if you're really busy, you're in the emergency department, you only have maybe 10 minutes with a patient, you realize they're unimmunized, you don't have the time to delve into there. You have a time to maybe make a plan for how they can address that, or maybe they can see somebody about it, but you can focus on that positive interaction because it helps build that trust and confidence that people need to go ahead and vaccinate later on. And then I just could not, we cannot talk about vaccine hesitancy unless we talk about having tailored interventions that first start with access. The top two predictors of low vaccination rates are no high school education and concern on vaccine availability and distribution. We cannot, as healthcare providers, fix the high school education, but concern of vaccine availability and distribution, in other words, vaccine access, we can advocate for and we can change how people have it. And through the pandemic, there were so many data that show that improving access to health insurance in the US, primary care providers, routine preventative care services were critical in reducing vaccine hesitancy, especially in that equity seeking and deserving group. So this group, so we're talking, access is an equity problem. When we make vaccines more accessible, then we make the vaccination effort more equitable to people. And that's really key. I'm a firm believer in including more vaccines in the school vaccination programs. I know that nobody wants to think about that in terms of influenza and COVID, but I think that's, to me, every healthcare interaction should be an opportunity and a chance for us to vaccinate and protect people. And and that also goes to say that a lot of the success of vaccination programs have been when these vaccines have been in the hands of pharmacists, especially community pharmacists, because that's where the access is. And that's where it's easy to come in and drop in and have multiple appointments done at the same time. And I urge my pharmacy colleagues not to limit the hours, which did happen a lot, unfortunately, with COVID, they were giving vaccines, because access is the lowest hanging fruit on the whole vaccine hesitancy scale. And I am a pediatrician, so I have to tell you about the need to pivot education to children, because today they're our patients, but tomorrow they'll be your patients. And right now, a lot of what we do in vaccine education has to addresses parental attitudes, but we need to pivot to the kids. And I think we need to bring education into schools, and we need to change their scientific education palette. We need to build a palette for these kids where they can differentiate between distrust and mistrust, and what's a valid and trustworthy source of information. And we need to do it at the school level. And I don't know how school boards are in other parts of Canada, but for us, for example, in Alberta, it's very hard to get into the school system to actually promote vaccine education. And we need to continue to advocate and push for that at all, across this country, and I think across the globe, because if we introduce this into the elementary school curriculum, then those kids can take it home and teach their children about it, their parents about it. And I know I've learned a lot from my kids. And then the last few minutes I'm going to spend on the healthcare workers, because believe it or not, you are still the most trusted source of vaccine information. So much has been done on this, and around every vaccine, every population, before pandemic, post pandemic. Thank you. During the pandemic, the healthcare workers were the most trusted source of vaccine information. So your recommendation, a recommendation from a healthcare provider, is still the most influential aspect of vaccination behavior. The onus is still on us. But we also know that a lot of us have had advocacy fatigue. A lot during the pandemic, our healthcare providers were feeling guilty, were feeling angry. There was a lot of confusion and fear around vaccines. And even now, when we've asked healthcare providers in primary care, they feel that having a vaccine conversation is actually going to build distrust or mistrust with their patients. Interestingly, we asked that of the patients, and the patients said they were a bit worried to bring up the vaccine to the healthcare provider. So really, here goes. Do not hesitate to have that conversation, because the patients still have their questions, still need that support, even though we may perceive that they may not want to hear about it. Interesting that they still want to have our support as we encourage them to vaccinate. So I'm going to spend the last couple of slides on this, and what can you do on that one-on-one interaction, especially if you're seeing a specialized population and you may not know a lot about vaccines and be a vaccinologist yourself. So the next couple of slides are just to address that. The first aspect of vaccine communication is connecting before you communicate. That's building that common ground. If you don't have that, truly, there is very little point in continuing a vaccine conversation. So if you feel that we haven't really connected with that patient, it's probably not that fertile ground you're looking for to change their behavior. And then you have to show true curiosity and meet them where they're at. So that's also hard, because we want them to be at a certain place, and it's hard for us to sometimes just be and accept that they are actually in a very different position of vaccine uptake. But establishing the vaccine as the norm. And I'll talk a little bit about validating the emotion, but you cannot validate their ideas, but you can always validate the emotions. So you are establishing the vaccination as the norm. and always keep it very personal. Patients, just remember what I said earlier, patients make decisions around personal protection. So as soon as you find yourself getting into a philosophical discussion about vaccination, step back, because at that point it's no longer relevant to that patient. And at the end of the day, it's the patient in front of us that we want to serve and protect. So I would put this forward for you as a vaccine communication framework. It's called the PROTECT framework, and it's not going to fix all the vaccine hesitancy problems you're going to have, but it's going to give you a bit of a framework on how to address somebody around the vaccine discussion. So the first part of PROTECT is the presumptive statement. So a presumptive statement means that you're assuming that they're going to go ahead and have the vaccine. So let's say you're a pharmacist in a busy pharmacy, you're going to say to them, um, uh, um, I'm glad you're here here you are. I've provided you your, I don't know, asthma inhaler medication, refills, but I also have the influenza vaccine available and I can give it to you today. So that is a presumptive statement. A participatory statement may be, here are your refills. I have the flu vaccine. Do you want to take it? That is participatory. Presumptive means I can give it to you. So here it is. We can just go ahead and do it. You're presuming that they're going to go ahead and get vaccinated. The next part of protect is the O, and that's where you're going to step back a bit and you're going to hear what they have to say, and you have to have this open-minded listening. You're going to have to do a little bit of affirmation, so you're affirming what you're hearing, you're going to summarize, and you're validating their emotion. So you cannot validate the idea that measles vaccine causes autism, but you can validate the hurt or the pain, or that somebody that they believe their family member died of a heart attack from an influenza vaccine. But you can definitely validate the sense of the loss, and you can validate the hurt that has come from that, from an event in their lives. And then the next part is, after you've listened, you're going to offer to share your knowledge. So you can say, I'm giving you an example about the RSV vaccine. You can say, this is a vaccine that was just being, it's now available to us to protect patients against RSV. And I've actually educated myself and learned a bit about it for my patients, because I know how bad RSV was last year and how many patients end up in hospital. Can I share some of what I know with you? So you're asking for that. You're offering to share and asking for permission. And then when you do address it, you're going to address only the concerns they brought up, and you're going to tailor it to that patient. So if that patient is a healthy, non-immune compromised individual, do not talk about immunocompromised and the risks of whatever respiratory infection is in the immunocompromised, because that's not them, they're not listening, and that's not how it's relevant to them. And lastly, the last part of this protect framework is talking through an action plan. So I always kind of close the presumptive loop where I say, okay, well, let me tell you, I can give you this dose right now, or you can get this dose in a month. It's available on October the 15th, and it's an intramuscular shot. And so you're having an actual vaccine action plan when they leave that visit, so that they can that it goes back to establishing vaccination as the norm. So this is a short little approach to how you can have a vaccine conversation. We're actually building some virtual simulation games of the protect framework, specifically with a focus on the immunocompromised population, because we know that now we have all kinds of patients who are immunocompromised, and a lot of patients who are with potential lung transplants and other solid organ transplants who may be hesitant. Thank you very much, and I will now answer your questions.
Thank you, Cora. Actually, we have a question. There are still many healthcare workers who are unvaccinated. Would you like to comment on that?
Oh, yeah, I think that's really important, because what we know, and it makes total sense, is that if a healthcare worker is unvaccinated, then they're not going to recommend the vaccine to their patients. So not only are they a risk to themselves, they're a risk to their patients, but now that also goes down the line and says that, potentially we've lost other patients there because the fact that they're not going to recommend it. And I think probably, and more data are coming in on this post-pandemic, I don't think that has improved. I actually think that's going to be a bit worse on that. So absolutely, we need to focus on that. We need very tailored vaccine interventions, very tailored interventions to that population. And not all healthcare workers are going to listen to the same message. We know that from the pandemic as well. So we know that physicians are going to have a very different message than maybe pharmacists, and what they listen to and how they address that. And what's really important in healthcare worker advocacy is they want to hear it from their peers. So that's really key. So, me, the pediatric infectious disease specialist, is not who should be talking to maybe, some allied health staff that's working in the community clinic. Very different approach. We need vaccine champions that are within that healthcare provider role and field to communicate that to their patient, to their colleagues. Barb, I think you might be muted.
I am muted. There are many side. Oh, here we go. So here's a question. There are many side effects, particularly with the COVID vaccination, and some that we don't have data on. Where is the benefit risk ratio, especially when it comes to healthy children? So this almost, actually you only have 2 minutes, and that's the kind of question that involves. Yeah.
That's okay. I'll tell you my approach to that. So the reason we're in a different position now than before is that most of our children have had COVID. So there is some prior immunity at this point. That would have been a very different discussion, last year or the year before, because not as many kids would have had it. And we've had healthy children end up in hospital with COVID disease, sequelae, and acute COVID. There are some populations that in children that are going to be at higher risk. A lot of them are like the adults, so those immunocompromised, those with neurological conditions, heart conditions, etc., premature, those under 1. Those kids have a higher risk of COVID sequelae and severe COVID. In healthy children, you could argue that at this point, if they've had COVID in the past, potentially there is not the same balance of personal protection as it would be in a more vulnerable population. But I'll tell you this, our vulnerable children have not had their COVID vaccine. So we have a lot of kids with transplants who are, on immunocompromising agents who are not immunized. So our work is not done in this field at all. There's still a lot of advocacy around the COVID vaccine to be done in the pediatric population too. And one more thing, the thing about the side effects, people say that because you can never rebut it. So you cannot say, oh no, we know all the possible side effects, but we have billions of doses, in children, we have huge numbers of doses. So we do know the side effect profile of this vaccine. So I'm not going to, I think the benefit ratio in a healthy child who's already been infected may not be there this year, potentially. Who knows what it might be in a few years as our immunity may wane and the circulation may change. But the safety of the vaccine is pretty clear.
Yes.